Hi, I'm Jennifer Robinson from Spherix Global Insights, and I'm here again with Dr. Jay Wish from Indiana University, a well-known expert in renal anemia. And Dr. Wish, a couple weeks ago, we discussed some ongoings with the HIF-PH inhibitors, and since then there's just been a flurry of activity. We saw that roxadustat now has an AdCom, vadadustat has filed an NDA, and more recently, we saw some inconsistencies with some of the safety data that was submitted for roxadustat in their NDA. A lot of things have happened. What's your take on the most recent news about the safety data with roxadustat?
Well, the change in the safety data it certainly received a lot of publicity, but I'm not sure it's really that material in terms of the approval process. Really, the only thing that's impacted to any significant degree is the safety data on the incident dialysis sub-analysis, which I personally don't think is going to affect the approval. I mean, the major analyses are going to be on the non-dialysis patients and the overall dialysis patients. The incident dialysis patients, which did offer some encouraging safety data in terms of a superiority in the initial analysis, no longer has that advantage. But the non-inferiority with regards to ESA for the dialysis population and the non-inferiority with regards to placebo for the non-dialysis population still stands. It's still within the upper confidence bound. So I don't think that there's going to be any material difference in terms of the AdCom review of the data.
And you mentioned, I think that the last time we spoke about the very encouraging incident dialysis data. Now that that perceived advantage is maybe off the table, does this change your perception of
Well,
roxadustat at all?
it doesn't change my perception because it was actually a pleasant surprise that they demonstrated the superiority in the incident dialysis population in the first place. And I never really thought that this would be part of the label. I couldn't
Hmm.
imagine that the FDA was going to have a separate paragraph that roxadustat was superior to ESA in incident dialysis patients. I figured
Okay.
they're going to look at the entire dialysis patient population. They're basically going to go with the non-inferiority with regards to safety, and as a result, roxadustat would probably get all of the ESA black box warning baggage, because if you're non-inferior to something that's considered to be relatively unsafe in terms of black box, then you get that black box too. I didn't see a
Right.
carve out for incident dialysis patients. Oh, this is more safe, so don't
Right.
worry. That was never
Right.
going to happen.
Okay. And I think, you and I spoke before about the possibility of black box with roxadustat and the other HIFs. And I think it's all speculative right now, of course, but do you anticipate that roxadustat would get the same black box warning as ESAs at this point?
Yes,
Or,
yes, I do.
okay.
Again, I don't think there's anything that roxadustat has presented in terms of either public material or whatever they submitted as part of their NDA to the FDA that would indicate that they have anything different in terms of a safety profile versus ESAs. Therefore, they're going to inherit the ESAs. Black box baggage, so to speak. And we know that the FDA has been extremely conservative with regards to their labeling of all these anemia products, going
Right.
back to the change in the label for the ESAs that occurred back in 2007 and then again in 2011, where they became more and more restrictive with each iteration of the label as more and more of these data came out, first with the choir study and then with the treat study. So I can't imagine that the FDA is going to back off on that very conservative approach for the HIF stabilizers.
Yeah, that makes sense. So let's shift gears a little bit and talk about vadadustat and Akebia. So last week, Akebia got their NDA filed. It hasn't been accepted yet, but it was filed with the FDA for both anemia in hemodialysis as well as non-dialysis. And of course, as you know, the safety study in non-dialysis did not meet the primary endpoint of safety in MACE or non-inferior safety versus Aranesque. What's your take on whether or not they'll be able to pull off both indications?
Well, I wasn't sure whether they were going to actually go through with the NDA for the non-dialysis population, given those safety concerns. versus active comparator with the non-dialysis studies. They did choose to go ahead with the NDA. I think that NDA for the non-dialysis population is vulnerable because of the safety, the inability to demonstrate non-inferiority with regards to MACE safety in the non-dialysis population. I don't think there'll be any problem with the dialysis indication. You know, there you basically have the same thing as what you have with roxadustat. You have non-inferiority with regards to safety. You know, we have the precedent of Omontis, which I think is probably the best analogy, where they had almost an identical result. They had non-inferior safety with the active ESA comparator in the dialysis population. They were not able to demonstrate non-inferiority in the non-dialysis population. The sponsor decided not to go for the non-dialysis indication. They got the dialysis indication. Of course, it was subsequently taken off the market because of concern with regards to allergic reactions. But in that particular case, you know, the non-dialysis population was pretty much withdrawn. I think there was a lot of speculation that Akebia might choose to do the same thing, get the sure thing with the dialysis population, maybe subsequently apply for the non-dialysis indication with additional sub-analyses or other things to bolster that application. But they decided to go for the brass ring on both indications. And I think it'll be interesting to see how the FDA responds.
Yeah, absolutely. And so the AdCom date has finally been established for roxadustat. You recall their original PDUFA was the end of 2020, and then we got the delay, and then we got the notice of an AdCom. That's been established now for mid-July. With Akebia having followed, do you anticipate that this AdCom might more so be kind of a class AdCom? Talking about the HIFs?
No, I don't think so. I don't think the time with regards to the advance notice for the Akebia vadadustat application is sufficient to be able to include any of the vadadustat material in the briefing for the AdCom for roxadustat. And you need 55 days advance notice for an AdCom. So if you're going to convene two AdComs, say back to back, one for roxadustat and one for vadadustat, you can't do a class AdCom. They have to be on the individual products. So in other settings, they've done back-to-back AdComs. If there's more than one member of a class that needs to be addressed, they'll do them back-to-back so that the AdCom members can basically stay overnight but not have to make two trips. There's really not sufficient time to be able to schedule an AdCom for vadadustat back-to-back for the one for roxadustat. And I personally don't think there's enough time to incorporate any of the vadadustat data in the briefing document that the AdCom members are going to get for roxadustat. So I think the roxadustat AdCom will be a roxadustat AdCom and not a class AdCom.
Gotcha. And just in your experience and your best guesstimate, if you will, if it's a positive outcome from the roxadustat AdCom, how quickly might they be able to secure FDA approval?
Well, that's totally speculative. I get the feeling that the sponsors, FibroGen and AstraZeneca, are hoping for an approval sometime in the third quarter. So since the AdCom is occurring at the beginning of the third quarter in July, you know, that gives about 2.5 months that they could get that approval in the third quarter. If they get the approval in the third quarter, then they can go ahead and apply for the HIF-PH code and for the TDAPA, which require separate applications and can't occur until at least another quarter following the approval of the drug. So if you get you get the approval in the third quarter, you do your application for the HIF-PH code and the TDAPA, you could probably get that approval by the end of the year, in which case you could start, you know, with actually providing the drug, at least in the dialysis population.
On like a January 1 of the following year. Gotcha. And so if we work with those timelines, and I know it's a lot of ifs, there are a lot of speculation, but it definitely brings the potential time to market for Roxa and Vada closer together.
It does. Again, but it depends upon what kind of delays we see with Vada. I don't think anybody expected the delays that we saw with the Roxa. You know, you had an original PDUFA date back in December, then it got delayed by 3 months, and then it got the AdCom. Who knows what's going to happen with Vada?
So
Especially with this, very, very, don't want to call it fishy, but the safety data with VADA being what it is in the non-dialysis population, I don't think it's going to be as easy an approval process as Roxa was, and Roxa wasn't easy.
Right.
So I don't think you're going to see a clean sale for VADA, at least in the non-dialysis population.
Okay. Okay. I want to shift gears to something you just mentioned, which is TDAPA, and TDAPA is not very well understood by industry, by nephrologists at this point. Can you talk to us a little bit about TDAPA and its relevance for this class?
Sure. Well, I'll tell you what my understanding of TDAPA is, and this seems to be a moving target for me because every time I think I figured it out, it turns out that I was wrong, and then I have to revise my understanding of it. Okay, so TDAPA stands for Transitional Drug Add-on Program, and this was a program that was started about 5 or so years ago by CMS to encourage the development of innovative therapies in the ESRD space, because the bundled payment really disincentivizes innovation. Because, if you have a fixed bundle and you come out with a wonderful new invention that costs more money, then it's going to be very, very difficult for the inventor to get adequate reimbursement or reward, if you will, for that new invention, even if it improves outcomes. So the idea from TDAPA was that we would have a run-in period of 2 years following the approval of that drug for the TDAPA. See, I originally thought that 2-year clock started at the time of FDA approval, but no, the 2-year clock actually starts at the time that the HIF-PH code and the TDAPA are approved by CMS, which has to be at least another calendar quarter later. So everything gets pushed back a little bit. So again, as we said, if you could get approval for roxadustat by the FDA in the 3rd quarter, then you would apply for your TDAPA in the 4th quarter, or maybe in the 1st quarter 2022. Then that takes a quarter for you to get the approval for that. So it would either be at the beginning of the 1st or the beginning of the 2nd quarter, best case scenario, that the Roxa would get the TDAPA approval, and that's when the 2-year clock would start running. So what does this mean? It means it puts that particular drug in a separate reimbursement category outside the bundle, and it's reimbursed at average wholesale cost plus 0%. Okay, so AstraZeneca will set the average wholesale costs, and it will be reimbursed to the dialysis provider through Part B Medicare at that particular cost for a 2-year period. Okay. At the end of the 2-year period, it gets put into the bundle. The adjustment of the bundle, or the allowance in the bundle for that new drug, will be determined by the analysis that CMS performs during that 2-year run-in period with regards to the value of the drug. Okay. So suppose at the end of the 2-year period, CMS, through all of its analyses, and by value, we mean the value of the cost of the drug as an offset to costs outside the ESRD bundle. Okay. So if you're decreasing transfusions, or you're decreasing ER visits, or you're decreasing hospitalizations, and this can be linked to the use of the drug, then that's figured into the value of the drug. And then that value goes into the adjustment within the bundle that will then make that bundle higher or lower or the same. So suppose, for the case of one scenario, there's no additional value to roxadustat. Okay, at the end of the 2-year period, there's no change in transfusions, hospitalizations, as compared to standard of care, the patients who are continuing to get ESAs, for instance. Then what will happen is that roxadustat will go into the bundle. There'll be no additional adjustment in the bundle. And at that point, the dialysis providers can choose to use roxadustat or ESA, and it's not going to matter because the reimbursement will be the same. It's all going to be one fixed bundle. Suppose, for the sake of argument, that there's this dramatic decrease in extra costs outside the bundle, fewer transfusions, fewer ER visits, fewer hospitalizations, and other things that cost Medicare money, then that will go into the calculation of the value, and then the bundle might be adjusted upwards to so shall we say, incentivize the use of this new product, which decreases overall costs. So
Okay.
that's kind of how TDAPA works.
Okay, that's extremely helpful. A couple of questions on that. For this 2-year period with roxadustat, presumably, reimbursed outside of the bundle, will there be any adjustment to the bundle payment to account for the offset to ESA?
No, there will not. And that's another thing that I was mistaken until I was re-educated on this topic. So I thought that the dialysis providers would not be able to double dip, that they would lose the allowance for ESAs in the bundle if they were also billing for roxadustat in the TDAPA. And the allowance for ESAs in the current bundle is about $30 per treatment. So I thought that their bundle payment would be $30 less if they also billed for roxadustat outside the bundle through Part B with the HIF-PH code, et cetera. No, that's not the case. They do get to double dip. They will get the exact same bundle rate, even if they bill for roxadustat through TDAPA outside the bundle.
So I would call that an incentive.
That is a real incentive. I mean, it's free drug, and there's really no downside in terms of taking a hit on your bundle reimbursement. And I think that was the intention of the TDAPA, to encourage the use of these innovative technologies by providing what's essentially a financial incentive. You're still getting paid for ESAs that you're not using. You're getting free roxadustat through the TDAPA. And, I would be surprised if this incentive were not sufficient, unless there's some kind of, safety concerns to cause a significant uptake of roxadustat during that TDAPA period.
Okay. So if vadadustat gets approved a year later, do they get their own TDAPA?
Yes. Each drug gets its own TDAPA.
So if you follow,
so you could basically project that if you were a very savvy dialysis provider that wanted to get the maximum benefit of the TDAPA for all 3 of these drugs, which will be approved in succession, approximately 1 or so year apart, that you would ride the TDAPA for all 3 drugs and switch from one drug to another. Now, that may be easier said than done, because if you're a large dialysis provider and you adopt a new drug, I mean, you're talking about a change in the protocol that's going to be applied to, 100,000 patients, and that's something that you would generally want to pilot and make sure that everybody's on the same page. So, changing protocols is not easy, and it's not inexpensive. I mean, that all takes a significant infrastructure that in and of itself can cost a lot of money and labor and man hours, et cetera. So to basically HIF-hop, which is what I call it,
I love it.
One HIF stabilizer to another as each of them enters and leaves the TDAPA is not, a no-brainer. It will take some costs and effort on the part of the facility to change their protocol with each drug.
And I would almost think that vadadustat being in the middle might be the most vulnerable, because if you could ride Roxa for 2 years and then pick up Dapro, that gets you your max.
That is correct. It could put VADA in a difficult position. The other thing that could put VADA in a difficult position is the fact that it probably will be approved for daily administration in all populations. So roxadustat has a inherent longer half-life with 3 times weekly administration, which makes it ideally suited for administration in a dialysis unit at each treatment. Vadadustat has a shorter half-life. It will probably get a label for once daily use, and whether or not the TDAPA will cover that, because what will have to happen is that the facility will have to buy the drug and then give the drug to the patient to take at home on their non-dialysis days. It's not clear how that will work logistically. Daprodustat, on the other hand, has a phase 3 global trial that is specifically addressing the use of Dapro in dialysis patients 3 times weekly. So if that trial is completed and becomes part of the NDA for Dapro, they will probably get a label for 3 times weekly use in hemodialysis patients, which again makes it more friendly for the dialysis provider. So you're right, VADA is vulnerable for those reasons.
Okay. And then, my other thought in terms of TDAPA, this is only for the Medicare patients. And I understand that that's the predominant, payer for dialysis patients. But I would assume that Roxa will have kind of immediate opportunity for some of those maybe incident patients that still have their commercial. insurance.
That is correct. And since you mentioned the Medicare, remember Medicare only pays for 80%. So if the patient does not have a secondary insurance, then the cost of the drug, even in the TDAPA, is going to fall on the patient. So the TDAPA, like the bundled payment, only pays for 80%. So if you've got a fairly expensive drug, and it's anticipated that roxadustat will probably be somewhere in the neighborhood of 20 to 30% more expensive than the ESAs, then that additional premium is going to be passed on to the patient as part of their responsibility. So what's anticipated may occur is that the patients who cannot pay this, okay, and there may be a substantial number who don't have adequate secondary insurance, that the facility can use that 30% allowance that they're getting for the EPO that they're not using to offset the patient responsibility for the TDAPA Roxa.
And then still hopefully be in the black.
And still hopefully be in the black. Yeah.
Okay, that's helpful. Kind of last question for you, and you started to allude to it previously. We haven't seen as much data coming out about dapro from GSK. You touched on some of the dosing advantages that the product could potentially have if their trial is successful. Are there any other differentiators that dapro might be able to bring to the market that would give it an advantage coming in as feasibly the third HIF-PHI?
Well, it's really too soon to tell. Number one, because we don't have the global phase 3 trials. And as we saw for both VADA and Roxa, getting your whiskers for the safety data, underneath that, that upper bound of the confidence limits is not as easy as it may seem. So we have no idea what the safety data on DAPA are going to show. And again, VADA failed. And Roxa ended up having to change theirs, and their upper whisker is actually fairly close to 1.3 in the second analysis that was just released this week. For I think it's for the MACE in the non-dialysis patients, it's 1.27 in the new analysis. So again, this is a tricky thing in terms of demonstrating safety, non-inferiority. So we don't know anything in the global trials. All we have from dapro in terms of phase 3 trials is the Japan studies that have been published, but they're smaller. They're only 1 year duration. We know that there's non-inferiority with both regards to in dialysis and non-dialysis patients. We know that treatment emergent adverse events in both populations seem to be comparable to the active comparator, which was an ESA. So, it's encouraging news. It's basically what we saw in the earlier phase 2 studies of VADA and roxadustat. And again, we just don't know what the large global studies are going to show until the data are actually released. The studies, these are the ASCEND studies. There's 5 of them. I understand that 4 of them have been completed, and their data is currently undergoing analysis, and probably we will see top-line data on them sometime in the next 1 or 2 quarters. But I think other than that, it's difficult to speculate.
Yeah. Well, thank you as always. You give such a wonderful perspective. I appreciate you sharing your thoughts with me today. Is there anything I didn't touch on that you think is highly, highly relevant for this class and something we should all have our eyes on?
No, I think we touched on most of the headlines that have occurred in the last week or two. As you said, it's been a very, very active few days. I'm very, very excited to find out, what happens with the AdCom in July, which is just a couple months away. And hopefully the FDA will make its decision soon thereafter. I still feel that this is a very exciting class of drugs. And I'm actually more excited, even though we've been talking primarily about dialysis and TDAPA, about their role in the non-dialysis population because of their ease of use. I mean, this is a revolution in terms of patient friendliness because they are orally administered. They don't require parenteral administration. That means no shots, no trips to infusion centers. And for most of my patients, this would be much, much more compatible with their lifestyle and something that they would be much more likely to adopt. The big question also remains is what is the premium of these drugs over ESAs, and how is that premium going to affect how prescription drug plans tier them as far as prior approval? And I'm very, very concerned that they will make them, very, very high tier, that the patient will have had to fail an ESA, especially a least expensive ESA, like biosimilar. And that's going to take longer in order to get these drugs approved on any individual patient level. So, we'll have to see how that plays out.
I'm going to sneak one more in on you.
Okay.
What is your thought, when you're thinking about the non-dialysis population, what is your thought about primary care physicians ultimately prescribing this class?
I really think it depends on how spooked they are by the black box warning. Okay. And I think that's one of the barriers for them prescribing ESAs now. I mean, you hardly see any primary care physicians prescribing ESAs in non-dialysis CKD anemia because I think the black box warning scares them away. So really, it depends upon how spooky the black box warning is for the Roxa and the other HIF stabilizers. I think if it's still very spooky, they're going to be scared, and the patients will still end up getting referred to nephrologists. And unfortunately, nephrologists don't have the bandwidth to be able to see and treat all of these millions of patients who have CKD-associated anemia. It's estimated that in the United States, there's approximately 2 million patients with CKD-associated anemia, and there's only 8,000 full-time equivalent nephrologists. We just can't see and treat all of these patients. So unfortunately, if the primary care physicians are not comfortable prescribing these drugs, this will still be an unmet need.
Okay, great. Well, again, thanks so much. I hope you have a great weekend and really appreciate you spending the time with me this morning.
Thanks, Jennifer. Same to you. Have a great weekend.
Thanks.
Bye-bye.
Bye-bye.